how fast it's being down.
Hi, everybody. So we're just going to get started. Just want to respect everybody's time. It is 2 o'clock. I have started recording just so that those that are unable to, there's some people that are working today and tonight. So just want to have a recording for those team members so that they can watch. If you're able to have your cameras on, just so that I can see your guys' faces and I can take attendance as well. That would be wonderful, but if you're driving, unable to, please just be safe. Whatever you guys need, but would love to see your beautiful faces. Okay. All right, so I'm just gonna get started. I'm gonna go ahead and share my screen.
They're onesie up here for their like pick with their actions so they don't parent flat.
Okay. Are you guys able to see the fellowship medication assessment? And some head nods. Wonderful. Thank you. Thumbs up from Sue. Beautiful. Okay. So I'm going to go over the questions, and as I'm going over the questions, I am going to go over rationales of correct answers. 1 second. I did just see somebody, I think somebody was signing on. Let me just make sure everyone is admitted into the group. Okay, perfect. Now you guys can see all your faces. 1 second. Okay, now you guys are back to fellowship medication assessment, correct? Yes, okay. All right, here we go. So question number one was asking about a 32-weeker that you guys had admitted. Mom had a maternal diagnosis of choreo. What antibiotics or medications would you anticipate the provider to order? So the correct answer here was AMP and Gent are broad spectrum antibiotics. Vanc would only be if in a case where we've identified, what from the culture, what our baby has, and if it requires like the necessity of treating with Vanc. Hydrocortisone and caffeine also incorrect, and we will get to why we give those in future questions. Also, if you guys have any questions while I'm going through the med assessment, if you guys wouldn't mind coming off of mute, just because I don't have you guys, my little camera disappeared in the bottom where I can see all of your faces. So if you have a question, just come off mute and ask, so I don't miss your question. Okay, so first question, broad spectrum antibiotics, AMP and Gent for baby that we admitted with diagnosis of choreo. Question number 2, your patient has ampicillin ordered to be given at midnight. Where would you expect this medication to be located and how will it be prepared? Correct answer would be in the Omnicell drawer of the vial that contains the ampicillin powder will need to be reconstituted at bedside. It coming up through the tube station, that's something that we would expect with Gent. Pharmacy tech bringing it up, that would not be appropriate unless it was a controlled substance. The pharmacy tech would bring it up and you would need to sign for something like that. And then we do not refrigerate AMP for that first answer of in the Omnicell refrigerator. And it is not pre-made by pharmacy. We have to reconstitute at bedside. Question number 3, your patient is 3.5 kilos. Ordered dose of ampicillin is 100 milligrams per kg, and the concentration is 100 milligrams per ml. So this was just basic med math. Correct answer would be 3.5 mLs, and we just had like a bunch of different options here for however you wrote it out. Really, the only way that you got this wrong is if you did incorrect rounding. How is gentamicin administered? So the admission and the maintenance dose are both given over the pump over 30 minutes. So that's the correct answer there. All right, questions 5 through 10, you have this information here to answer those questions. So you have an intubated patient that has IV Fent, 1 microgram per kilo every 2 hours PRN dose. Your patient is 3.5 kilos. The concentration for the fentanyl is 5 mics per ml. What is the mLs that you would be giving for this fentanyl? And it would be 0.46 mLs. Again, the only way that you would have gotten this question incorrect was related to rounding. How will you administer the fentanyl bolus? So the answer to this could be found in neofacts. Really also kind of getting rid of the questions by, getting rid of the questions that wouldn't be correct. Over 30 minutes on the syringe pump, that's just way too long for fentanyl to, be effective in what we're giving it for in its pain management response. A rapid push, we don't rapid push anything in the NICU unless it's epi rescue med, so that would not be correct. Or if it was rock or adenosine. Then the correct answer would be slow IV push over 5 minutes with a flush of 1 ml slowly at the same rate. And then again, over 60 minutes on the syringe pump, that along with the 30 minutes, it's just not going to get that desired effect of the pain management that we're trying to get from the fentanyl. What are some possible side effects to monitor when administering Fent? So the 3 big things we're looking for here are respiratory depression, hypotension, and chest wall rigidity. Hypoglycemia is not a correct answer. These, again, can all be found on neofacts. Question number 8, you call your provider because the patient continues to fight against the ventilator and tries to grab the tube. The provider increases your PRN IV fentanyl dose, but also adds a PRN IV midazolam. What is midazolam or Versed used for? So correct answer here is it's used to treat agitation and decrease anxiety by inducing sedation. It is not a narcotic, but a benzo. So these other answers are incorrect. The big one that we really just want you to know is that it is not treating any sort of pain. That's what that PRN fentanyl is for. The Versed is just going to help with that, decreasing anxiety, treating agitation, sedating the baby. We're not treating pain here. That's why we give them together. Okay, question number 9. The dose of PRN IV midazolam is ordered for 0.1 milligrams per kilo, and the concentration is 1 milligram per ml. How will you give Or how much will you give and how will you administer it? So the correct answer, you have to do some med math here, but then also know how to add, give the Versed. So the correct med math would have gotten you 0.23 mLs. And then you always are going to give that over a slow IV push. Again, Versed is not a part of the meds that we would be giving rapid push. So you would give that over your slow IV push of 5 minutes. And then these last two are incorrect because of the medication calculation of 2.3. That's way too much. Okay, so Versed is incompatible with lipids, or midazolam is incompatible with lipids. Your patient currently has TPN and lipids running through a single lumen PIC. Assuming additional lines are not able to be obtained at this time, which of the following is the best method to administer this medication? So also kind of, going through the questions and eliminating the ones that are absolutely incorrect. So moving past our correct question, intralipids is a continuous infusion and you are able to give intermittent medications with a continuous infusion. This one is incorrect because we know that these two things are incompatible. So Versed is incompatible with lipids. So we would not be giving this just intermittently while our continuous infusion is running. Call the provider to request a switch of intralipids to SMOF. We would never just switch a baby to SMOF. We're switching babies to SMOF if they have those GI considerations that we're looking at. There is no other option, so we need to get another PIC ASAP. Also inappropriate in that we wouldn't introduce a new access or a increased risk of CLABSI just because our Versed and our lipids are incompatible. So the correct answer here would be to clamp the lipids, flush the extra port with 1 ml to clear the line, give the Versed, and then you would flush 1 ml after the infusion to clear the line again, and then you would clamp your extra port and unclamp the lipids so you could start continuously running your lipids again. All right, so then questions 11 through 15, you're using this information below to answer. You're admitting a patient with possible seizure activity from the PACU. On admission, you notice rhythmic movement of the arms and legs, tongue thrusting, and abnormal eye movement. You immediately inform the provider, and when examined, they decide to order a bolus of phenobarb. Your patient is 3.5 kilos. So these next two questions would have been a great resource to use would have been Neofax, because you would have been able to find the loading dose and the standard concentration. So the ordered loading dose for phenobarb would be 20 milligrams per kilo IV. And then the standard concentration of that IV phenobarb would be 65 milligrams per ml. Again, referenced in Neofax. How will you administer this phenobarb loading dose? A lot of people on on the unit believe that phenobarb, the loading dose, the first dose that we're giving, needs to be given slow IV push, almost kind of with the mentality and the mindset of like it's like D10, where we need to get it in quickly, like it needs to be fast acting. This baby is seizing, but that's not actually evidence-based proven. We need to be giving that loading dose over 30 minutes on the syringe pump, and that can be found on Neofax as well. How many mLs of phenobarb would you administer? So you would really just go back up to this question with the weight of 3.5 kilos, your loading dose, and then your concentration to get the final amount of 1.08 mLs. Again, only reason that you would have gotten it wrong is if the rounding was incorrect on this answer. What are signs and symptoms that you should monitor for after phenobarb admin? So the three big things are respiratory depression, and in our patient population, we're going to see apnea and hypotension. So we were looking for those two answers here. Hypoglycemia and tachycardia are not signs and symptoms that we're monitoring for. Okay. Then questions 16 and 17. So you're admitting a transport 2-week-old, 27-week gestational age infant from a neighboring hospital with acute respiratory distress. The infant is admitted on the jet with a PIP of 38, PEEP of 13, rate of 300, I time of 0.02. And FiO2 is at 100%, and we are starting nitric or have nitric running at 20 ppm. On admission, the infant's vitals, temperatures 36.7, heart rate 160, MAPS or 22, and SAT is 90%. You're reviewing your orders and you see that the provider ordered a one-time dose of IV hydrocort, 1 milligram per kilo. The hydrocortisone concentration is 1 milligram per ml, and your baby's weight is 1.2 kilos. So lots of info there. But really biggest thing that we wanted you to take away from, these things that it comes in the data and the information in this question. So why did the provider order hydrocortisone? So we went over this in Jeopardy, in your guys' prep for the medication assessment, also in your med lecture that we did in system class, as well as something that you can find on Neofax. But the use of hydrocortisone in our patient population is to increase the expression of the androgenic receptors in the vascular walls, increasing that vascular activity in hypotensive babies that are cortisol deficient. I feel like a lot of people see hydrocortisone, a steroid, and they think they want it's to decrease inflammation in the lungs. That's not where we're at. And especially if you look at this baby being 2 weeks old, 27 weeker, we're not at the point where we're thinking about chronic lung. We may be developing it, later on down the road in this history, but that's not what we're looking at it for right now. We're looking at it for that, for the babies that are cortisol deficient and their adrenal glands are just not at the place where they're able to keep up. So it's going to overall help with these MAPs of 22, helping the hypotensiveness of this baby. For our patient population, how we would administer hydrocortisone, this is a slow IV push. Something you can look up on Neofax, rapid, inappropriate, 20 or 15 minutes, unnecessary. Okay, so you're taking care of a baby that is on NAVA, receiving continuous feeds, and has a transpyloric OD tube. Your patient also has an OG tube to vent the stomach and for medications. You're planning your 3 a.m. feeds and hands-on care time, and you look at the MAR to see if multiple medications do. We've got morphine, multivitamin with iron, sodium chloride, and caffeine. So what of these medications must be given OG? So that medication is going to be morphine. It's one of the red meds on the enteral feedings resource guide. Morphine is can be very, very harsh. And if that was given into the small intestine, that would be no good. We do not want that. So that's one of the red meds that we would not be giving transpylorically. The other 3 we can give through the OD tube. How will you give the OD2 meds at 3 a.m.? So this was an open-ended question. Really, the biggest things we were looking for here is that you are putting the medication into the feed. You are not just pushing medications through an OD tube. You're putting the medications into the syringe, mixing them in the milk. And we loved the extra bonus of when somebody said that they would put the medication label on the syringe. But really the biggest thing we were looking for here, because we know it's an open-ended question, the biggest thing we're looking for here is that you are mixing the medication into the feed. The only way that you got this wrong was if you said you didn't address it at all, or it just was blatantly said that the medication was pushed through into the OD tube. You're taking care of a 2-week-old 28-weeker. They're scheduled for caffeine at 1 a.m. Order states the dose is 10 milligrams per kilo, concentration 20 milligrams per ml. Your infant is 0.85 kilos. How many mLs of caffeine will you be administering here? So it's going to be 0.43. Again, rounding were the only reasons people got it incorrect. What is the mechanism of action of caffeine? So the correct answer here is the bronchial smooth muscle relaxant, a CNS stimulant, and a cardiac muscle stimulant and diuretic. This was literally pulled right off of Neofax under the pharma mechanism of action category in Neofax. All right, and then questions 22 through 24 pertain to the information of you're admitting a 33-week gestational age infant who weighs 2.5 kilos, and the first blood glucose is 38. So provider orders a D10 bolus. What is the dose for this infant? 2 mLs per kilo. Our babies are too sweet. What would be the total volume of the D10 administered? So you would just be taking that 2.5 to 2 mLs per kilo to get the total of 5 mLs for that D10 bolus. How will you administer the D10 bolus? So again, just like process of elimination, we would not give it over 30 minutes or over 60. That's just not giving us the desired effect of treating that hypoglycemia. We would be giving it over a 1 to 5 minute push. And now for admissions and D10 boluses, it will say in the MAR slow IV push over 1 to 5 minutes. Okay, you're using the following information to answer questions 25 through 27. You're admitting a 40-weeker with a maternal history of partial abruption. Infant weighs 4 kilos. On assessment, the infant is pale with low BPs. You've taken multiple attempts to get access on this infant. What would you expect the provider to order? So we're looking at needing to, get some volume on board for this baby. So we would want full 0.9 normal saline bolus. What would be the ordered dose? We want our babies to be the perfect 10, so 10 mLs per kilo. And then again, just taking that 10 mLs per kilo of the weight of 4 kilos and the information above to get the total of 40 mLs for that admission bolus of normal saline. Does anybody, and that's it. Those are all of our questions. Does anyone have any questions about the med assessment while they were taking it, feedback for us of things that went on while you guys were taking this at home, or anything that I can cover that I didn't from going over the questions?
I don't have a question, but I do have a comment about number 20. So
Yeah.
I'm pretty sure I put 0.43, but I didn't put ML because they didn't say you had to put a ML, and I think I got that one wrong.
So we read the answers and go through. As long as you had 0.43, we
Oh,
counted
okay.
it correctly. Yeah, because we knew
Okay.
what you were getting at. So it's not automatically graded. We go through and answer all the questions. We just add all of those like options for MLs in case like it gives some kind of weird glitch and doesn't count it wrong for you. But really the only reason anybody would have gotten any med math questions counted incorrect would have been because it was not the number that we were looking for.
Okay, thank you so much.
Yeah, absolutely. And if anybody has any questions about like, even after watching this debrief, I'm not really sure which ones I got wrong. We're happy to go over it with you, but just like communicate that with Jordan or I, and we're happy to pull up the test and go through the questions with you guys and rationales for answers if, even from this debrief, things still feel a little open-ended. Okay. Any other questions?
I do have a question, but it's
Yeah.
related to scheduling, so it's not really
Sure. Do you want to stay on afterwards and I
Yeah.
can answer? Okay, sure, no problem. Awesome. Any other questions I can answer for you guys related to med assessment or related to anything else?
I also have a scheduling question.
Yeah, you want to stay after?
Yeah, please.
Okay, awesome. Okay. Awesome, guys. Well, thank you so much for tuning in, and we'll see you guys soon, okay? Just let me know if you need anything.
Okay, thank you.
All right. Bye, guys.
Bye.
All right, guys, let me just stop recording.